Good evening and welcome to the Cancer Education Series, which is brought to you by Mercy One and Above and Beyond Cancer. My name is Chris Goodale and I'm the Executive Director of Above and Beyond Cancer. It is my pleasure this evening to introduce our founder, Dr. Richard Deming, who will introduce our speaker. Dr. Deming?
Great. Thank you, Chris. Whoa, let me turn on my video. There we go. Hi, everybody. Thanks, Chris. And it's my honor to introduce our speaker tonight. Our speaker is Dr. Taylor Vanden Wynboom. And Taylor went to high school in Britt, Iowa. And I happen to know that that is the hobo capital of the universe. I went to college at South Dakota State University, and our homecoming happens to be known as Hobo Days. So I've, for many, many years, known about Britt, Iowa. Taylor then did his undergrad work at Central College in Pella and got his chiropractic degree at Palmer Chiropractic School in Davenport. And he is in practice here in Central Iowa, and he is owner and practitioner at the Nova Integrated Health Center in Ankeny. And I've asked Taylor to talk about neuropathy, peripheral neuropathy. It's a real problem that many patients who've undergone chemotherapy and some patients that undergone radiation have experienced. Neuropathy is also something that can develop for other non-cancerous related problems. And there's not just a quick, easy solution for how to take care of neuropathy. As a doc who cares for a lot of patients who have neuropathy, I'm often looking to what I would call integrative medicine techniques, something besides just a medication to help with neuropathy. And came across Dr. Taylor and asked him to talk about the various modalities that may be helpful for patients who are experiencing neuropathy. So without further ado, I'll turn it over to Taylor. Thanks.
All right, let's see. Get this screen share up. Let's see here. And there we go.
We got it.
And get that back to the front, eh? All right. So yeah, as Dr. Deming said, my name is Dr. Taylor Vanden Wynboom. I am a chiropractor. I go by Dr. Taylor for obvious reasons. If anybody tried to say I go to Dr. Vanden or nobody would know who they went to. So when we look at things, we're going to talk about decreasing the symptoms of chemotherapy-induced peripheral neuropathy. But really, these things go in hand for any type of neuropathy. Like I said, my name is Dr. Taylor. I'm the clinic director for both Nova Integrated Health in Ankeny, Iowa, and physical therapy and balance centers also in Ankeny. So just a little background for people who might not know exactly what peripheral neuropathy is peripheral just means far away from. So when you're looking at peripheral neuropathy, you're looking at the nerves related to the hands and the feet, right? So far away from the central nervous system as far as the brain and the spinal cord themselves. Neuro means related to nerves, and pathy means disease. So like I say, we're talking about the peripheral neuropathy and the conditions that result in those peripheral nerves, hands and feet, and how they're damaged and diseased. Typically with peripheral neuropathy, you'll see the feet usually have involvement first, secondarily into the hands. And of course, it can progress from there, go feet up, ankles, knees, all the way up the leg, and those things as well. Symptoms with neuropathy can really vary from patient to patient. I have them kind of big categories as far as pain, numbness, muscle involvement, temperature differentials. There's lots of subcategories underneath that. So like say with pain, you're talking about stabbing, sharp pains, burning, electrical shocks, stinging, aches, tingling, pins and needles. A lot of patients will talk about this tightness that they feel. A lot of times say that their toes feel like sausages, but if they look at them, there's not really a lot of fluid retention or actual edema in those areas. Numbness obviously is a sensory issue where the patient is losing feeling in those areas. So numbness can bleed over into a lot of different areas like balance issues. I put pins and needles under this too because some patients will say pins and needles is more of a numbness. Some will describe it more as pain. or like a dead feeling in their foot. So when you look at numbness, obviously that's a bigger issue. And when you look at it nerve-wise, you talk about your sensory nerves. One way you can really decipher if you're having a numbness issue, because a lot of people will say, well, I feel like my feet feel okay. And then obviously once we check them out, you know, they're having some differentials with that, especially with balance, is your body works on what's called proprioception, is where does my body perceive itself at in space. So if your feet can't give the sensory information to your brain as far as where you're at, you're going to have balance issues. And an easy way to tell this is, for instance, if you're in the shower, because when your eyes are open and you're walking, you can see the contour of the land, you can see, you know, things in front of you, you can actually see your foot hitting the ground, all these different things. Your body, your nervous system is really good at making up for deficits. So when you get into the shower and you go to wash your hair, a lot of people, once they close those eyes, will really get off kilter and really start to notice balance differentials in that aspect, because now you've taken the eyes out of the equation and you're going strictly based on proprioception, is where my feet tell my brain I'm at. And if you're having sensory issues, you're not getting full communication to the brain from those feet. Another check, like say if you get up in the middle of the night to go to the bathroom and the lights are off, you know, it's the same thing as having your eyes closed. If your balance is really bad at that point in time too, of course, that's going to be another sensory nerve loss issue. Muscle involvement, you can get some of that foot drop, you know, instead of the foot having a nice strike pattern, kind of that heel to toe action. You know, what's going to happen is you can't plantar flex or dorsiflex like you're supposed to. So you can't bring that front of the foot up. So when you're actually walking, you're kind of dragging across, and that's where you can kind of catch the front of that foot on things, make a lot of tripping issues with that. Then you can have temperature differentials, as far as a lot of people describe it as their foot might feel ice cold, but if somebody were to come up and actually touch their foot, the foot is normal temperature. Or they say it's really hot, but same thing, it's normal temperature as far as that goes. So as far as the symptoms with neuropathy, really, you know, we've seen patients that have had all of them. We've seen patients that just have pain, some people that have just numbness, and some people that have the pain and numbness, and they'll say, well, how can I have numbness and still have pain at the same time? And the real reason for that is they're related to different nerve receptors, right? So you have different nerves that do pain reception, and that's how you can get the different pains. You have different nerves that do sensation. So if you have your sensory nerves affected and your pain receptor nerves affected, that's how you can have both numbness and extreme pain at the same time. And the cause of neuropathy, you know, we won't touch on a lot of these, right? Because obviously we're talking about more of the chemotherapy induced. Probably the highest category of people with neuropathy are diabetics. If you're diabetic, there's a 60% chance at some point in time you will develop neuropathy. And there's very specific causes for that. Obviously chemotherapy, there's alcohol-induced neuropathy, there's nutritional and vitamin deficient neuropathies, there's kidney neuropathy, would be like uremic neuropathy, thyroid disease can cause neuropathy, obviously back issues can cause neuropathy. So when we're talking about interventions at our office, I am a chiropractor, so if there was a back-related neuropathy, that's where potentially an adjustment would come in. But me as being the clinic director, a lot of the therapies we'll talk about in a second here, I personally don't do, right? Because they're medical interventions. You know, I'm not going to poke you with a needle. I'm not going to do certain things because it's not under my scope of practice. So that's how we can help people with these other types of neuropathies. So you can get neuropathy from low back issues, and that's really where a chiropractor could help. We have 3 nurse practitioners on staff and a medical director who oversees what they do, and I'll explain all what they do here in a second. There's also inherited disease type neuropathy like your Charcot-Marie tooth, which is a genetic disease. Certain medications can cause neuropathy. You know, obviously chemotherapy, but underneath that, probably statin drugs are probably the biggest aggravator. Besides that, there's also autoimmune diseases, and the list goes on. Lots and lots of different potential causes. So when we look at chemotherapy-induced peripheral neuropathy, it's really different than most of the other neuropathies that we deal with or that there are, right? Because the cause is very specific, right? So when a person has chemotherapy-induced neuropathy, typically they know, you know, hey, it was chemotherapy treatment number 12, neuropathy started. Number 8, that's when the feet went numb and the pain started. So it's very specific on when it happens. Typically, you won't see a patient, but we have, who has chemotherapy-induced neuropathy that happened after treatment, right? Typically, it happens during, you notice it right away. It's different also because it's also a chemical killing of the nerve, right? As opposed to blood sugars with diabetic causing neuropathy. You know, potentially you're looking at that, it's more of a vessel occlusion that can be happening, right? Because if you're diabetic, you have higher risk of heart attack and stroke because of, you know, diabetes will clog your arteries, right? Because of arteriosclerosis, increased inflammation, all these different things. Well, you look at the capillaries that feed the peripheral nerves, so it's the same deal, central nervous system, spinal cord, peripheral, far away from. Well, the capillaries from the heart go all the way down to the feet, or excuse me, blood vessels go all the way down to the feet and form these really, really small capillaries that actually feed these nerves, vitamins and nutrients that they need, oxygen that nerve system needs to function and work like it's supposed to. So those vessels can become occluded and can cause nerve death, right? You stop feeding your nerves, they die. You stop feeding anything, it dies, right? So with neuropathy chemically induced, yeah, like I say, it's just a very sudden type neuropathy, like I say, and very specific cause. So you see I have on here many times it's easier to treat, which might seem counterintuitive because neuropathy in general is not easy to treat. But when we see it, it's more, you know, if we're looking at success rate, it's a higher success rate because we know very specifically what caused the neuropathy as far as, okay, they went through chemotherapy, the chemotherapy caused the neuropathy, they're not getting cancer treatments anymore, so now we know that a causative agent isn't there, really. It's because nerves are the slowest healing tissue in the body, right? They heal about 1 centimeter per month, right? So really, really slow. And typically you'll hear, hey, you had neuropathy, you know, there's this 2-year window that, you know, symptoms might go away, nerve system can regrow and all those different kind of things. So when you're looking at, like I said, chemotherapy-induced neuropathy, knowing the very specific cause and that aggravator is gone, it makes it a lot easier to treat a patient than, say, with diabetes, who you have to then give a lot of education as far as, hey, you have to get your A1C down. You're at running 6.9, and that's giving you like, you know, 160s to 170s. Blood sugars on average is just way too high. You're going to continue to kill those nerves. And that analogy would be something like, you know, you can't build a house if it's on fire, right? So we'd say, hey, we got to put that fire out first. Then we have to build up the building, and you got to keep that fire away if you want it to stay where it's at. So there's a lot more goes into it, which isn't a problem. You know, we educate all of our patients on health, you know, what to eat for neuropathy, things you can take for neuropathy, all things that help the nerves heal and regenerate, and do those kind of things. But like I say, with the chemotherapy induced, it's just more specific, and it's just, in all honesty, easier for us to deal with, which is a good thing. And then I have down here this 10-year window. And realistically, what we've seen just from seeing hundreds of neuropathy patients is chemotherapy-induced neuropathy, for whatever reason, there's this 10-year window that we've seen with our patients that if they're 10 years out from chemotherapy, they become a lot harder to help. Anything within that 10-year window is pretty straightforward across the board. Obviously, the faster somebody comes into our office, the easier it is to help them. But yeah, that 10-year window, once you get past that 10 years, you know, we might say, hey, there's maybe a 50-50 that we can do something for you. Just to be honest with patients as far as those things go. So testing measures. So, you know, a patient comes in, one of the things you want to do is you want to see how severe is their neuropathy. And there's lots of different tests for neuropathy that you can do. You know, if you go to a neurologist, you're typically going to get your nerve conduction velocity, a surface EMG, which are fine tests. You know, those tests test large fiber neuropathy. Typically, when you're dealing with peripheral neuropathy, it's a small fiber neuropathy issue. So we've had lots of patients that have come in that have had the large fiber test come back negative, but then the small fiber test comes back positive. So typically, the first test we start out with is what's called the Toronto Clinical Scoring Exam. The reason we start with that test is it's non-invasive. It's something we can do multiple times throughout therapy to track patient progression, make sure clinically people are getting better. And that test itself gives us a percent of nerve damage on one foot compared to the other, or one hand compared to the other. So we look at the Toronto, if you look at the clinical research for it, it correlates very, very highly as far as nerve testing, nerve damage, and the percentages that you get with the actual Toronto score. It is a subjective test, so there is a little bit of, you know, grain of salt with it. So, you know, if somebody comes in and percentage is 80% nerve loss, you know, there's probably a 5% gap on either side as far as, you know, it could be more of a 75 or an 85, but overall it's pretty accurate. Another test that we could do is what's called an epidermis nerve fiber density test, or an ENFD. And that's the small fiber neuropathy test. That's a 3 mm punch biopsy of the skin. Send it off to lab, they look at it in a microscope, and they'll tell us how many nerve fibers are in that sample. So they know, just based on age, how many nerves are supposed to be in these specific areas, based on just clinical, tests and evaluations. So what we can do is we can say, say Mrs. Jones comes in, and she's 80 years old, and we do a punch biopsy by her ankle, and let's say normal nerve density for her age is 0.8 density. We get her sample back. They look at it. They say, well, she's at 0.4 density. Well, then we can give a clinical diagnosis of mild, moderate, or severe neuropathy based on how much nerve density is lost, right? So if the nerves are gone on the density test, they're not hiding. They're dead, right? Nerves don't hide. So when we look at that, we can, very clinically say, yes, you have neuropathy, and here's kind of the category that you fit in with that. And those tests, depending on how severe or how progressive neuropathy is, you could do ankle, knee, hip, to get a progression study on that as well. And we like to do those typically pre and post treatment. The reason for that is it's a black and white clinical test that we can't change, you can't change. It is what it is. So if Mrs. Jones comes in at 0.4 density, she's supposed to be at 0.8 density. We do all the things that we do for her. She feels a lot better, which is great. And in all honesty, for me, the only thing that matters is, does the patient respond? Do they feel better? Did we help them? All the clinical tests in the world are great, but the reality of it is you have to improve the patient's quality of life in order for them to be a win at our clinic. But let's say we do the test, right? 0.4 density at the beginning. And then at the end of treatment, we retest, right? So we redo the punch biopsy, and it comes back at 0.5, 0.6, 0.7, whatever it goes up to. What's happened there is we didn't resurrect dead tissue, right? It's impossible. We can't bring back dead tissue. So what we've actually done is we sprouted new axons from existing nerve tissue to take over the actions of the nerves that are dead, right? Because what's happened is you repopulate that area with new nerve tissue, but it's not resurrected dead tissue, it's new tissue. So if the cause of neuropathy is either nerve damage or nerve death, if you can help the damaged nerves heal, and then the dead tissue you can't bring back, but if you can repopulate that area with new nerve tissue, what's going to happen to your symptoms? Logically, they're going to go down. And our goal for every patient, just to set the bar somewhere, is we want to reduce your symptoms, whatever they are, pain, numbness, foot drop, whatever it is, by 50% in order to be a success at the office. Thermograms we also do just to check the temperature differentials in different areas to see, hey, they have decreased blood flow in this area potentially because, the thermogram came back at a really low temperature, just to increase that blood perfusion. Because realistically, just like we talked about with the diabetic-induced neuropathy, if you have bad blood perfusion to those areas of the nerve, you're not feeding those nerves with what they need, they're going to get damaged faster and die. We also use what's called the FAOS, which is just the foot and ankle ossteometry. And that just gives us functional impairment and improvement, right? So we can test at the very beginning. It's a questionnaire, and then we can do that multiple times throughout therapy. Because what happens is nerves, even when they regenerate, even with what we do, it's still a slow process because nerves, like I said, are the slowest healing tissue in the body. So think if I'm a 300-pound individual, I'm losing a pound a day for, a year, okay? Or let's say a pound a day, or let's say a pound a week for a year. So 52 pounds over a year, right? So as I go through that, I'm 2 or 3 months in, I don't feel any different. I don't think I look any different. But if I see somebody who hasn't seen me in those 2 or 3 months, they're going to say, hey, what are you doing? You look a lot better. It looks like you've lost weight, right? Because it's such a slow process when you're going through it, it's hard to compare. So with the FAOS, our goal with this is just to say, hey, let's try to put back on your old feet. Remember, you came in, your functional impairment was like 80%. Right now, your functional impairment is 40%. You couldn't do this before. You had pain, you did this before. Because what will happen is patients, their memory on these things, right, when they start feeling better, becomes very short term. They'll say, well, nothing's really changed. You say, well, Mrs. Smith, you couldn't do any of this stuff when you first came into our office. Now you have no problem doing any of it. And then it'll kind of click, say, you know what, you're right. And it's good to have those different things that you can test throughout therapy to show, hey, clinically, you're better. And really, like I say, that's a great thing too. So let's talk about therapy itself and what we offer for our patients. So the first therapy that we do on almost every neuropathy patient is called electrical cell signaling. And here's a big, long, technical, explanation of what electrical cell signaling is. And don't ask me why electrical cell signaling is abbreviated EST, but it is. So the EST system delivers energy to the affected area of your body at varying wavelengths, including both high frequency and middle frequency signals using both, my screen's over top of this, both amplitude modulated and frequency modulated signaling. The system automatically changes to simultaneously deliver AM and FM electrical cell signaling benefits. And you can kind of see some of the technical things that it does below. The reality of what the machine does is it increases the body's ability to heal, right? They found clinically increases what's called cyclic EMP, just another technical term for the body's ability to heal, which obviously for nerves is very beneficial, with them being the slowest healing tissue in the body. So this therapy is made by a company called Synexus, and the company doesn't really matter. But they themselves have over 30 published articles specifically for nerve damage, nerve regrowth, pain reduction. So even those ENFDs that we talked about before, those epidermis nerve fiber density tests, we send those out, obviously without any patient information, but just results to take place in clinical trials and putting together data, just so we can have more and more things just to prove clinical efficacy, right? And all those things are important, right? We don't want to just say, well, potentially hypothetically it does these things. Or we can say, hey, clinically through research, these are the things that happen with what we're doing. We can deliver it to our patients and help them. And those things are important, like saying. The next slide will show a picture of the machine itself. So what you see is, yes, it is electrical based, right? It's not a TENS unit. You can get a TENS unit at Walmart for 10, 20 bucks. The difference with a TENS unit, because everybody just hears electrical medicine and they assume TENS or some kind of a STEM unit, is TENS works at one frequency, right? That you can increase the intensity or decrease the intensity in, that tries to overcome the action potential of the nerve, which will contract a muscle. Which is fine and dandy. Our machine will contract muscles too, just because you're putting those electrical signals and it has to go through muscle tissue too, right? And then what you'll see is on the side of this picture, there's these four what are called vasopneumatic devices. So the vasopneumatic device is important from a couple of different aspects. There's one, if you're looking at chemotherapy-induced neuropathy, a lot of patients, if you potentially had some lymph nodes taken out, might have some edema, right? Edema can actually affect and cause more neuropathic changes too, just from hydrostatic pressure and just actually compressive force of the fluid retention. So vasopneumatic device actually does help push out any kind of inflammation, edema issues in those areas. Actually, I have a cup here. So the cup itself, right, has this metal plate inside of it, right? So it creates this vacuum seal and does very specific pumping action that's programmed on the machine. Inside of it is a metal plate. You put a very specific sponge in there, connects the electrode, connects to the machine, puts in the electrical parameters to activate that cyclic EMP to help those nerve, and it's not nerve specific, but help the tissue regeneration and healing process. So this machine has been around for a long time. It'll sound like it's, space age or, why have I never heard of this before? It was been in Europe for over 20 years. It was FDA cleared in the United States in 2003. Is it newer to Iowa? Yeah, we're the first clinic in Iowa to have it. And we've had it for a few years now and does a really good job at everything that we use it for. We look at the machine itself. So, and I kind of touched on it earlier, is when a patient comes in, we give them this 80-page book that we put together as far as, hey, these are foods that are good to decrease inflammation, which is good for both cancer, right? And neuropathy, right? Because anytime you have that inflammation, it's going to cause issues. Here are exercises that are good for neuropathy. Here's all these really good things for neuropathy, but in there you also have what's called the white paper. So medical devices should have a white paper on them, right? Which goes over how the machine works, technically what it does, all that kind of stuff. So we give you all that information if you come into the office. You can always just request it from us too, because we want you to be as educated and informed on what we're doing and why as possible. We want everything to click. We want it to all make sense. So we give all that patients all that information because we think it's important. Depending on the patient and the actual percent nerve damage. So our interventions aren't a cookie cutter approach. It can't be, right? There's just too many different types of neuropathies, too many different categories of severity. So when you look at those things, what we recommend per patient really depends on the patient, how much nerve damage they have. And that's where obviously coming into office, we can decipher those things and give you a very specific recommendation. So the Synexus unit, the electrical cell signaling, we actually do on every patient, right? So if a person comes in and they're above 40% nerve damage, which is actually quite a bit, we might also recommend this nutrapharmaceutical blend of injections. So it's a combination of B12, B complex, vitamin C, glutathione, which are both antioxidants, L-carnitine. Those are all put into one specific mix along with sodium bicarbonate. The reason we use sodium bicarbonate is because vitamin C is acidic, so it kind of neutralizes that acidity out. And then lidocaine. And lidocaine's in there for multiple different reasons. As lidocaine is a vasodilator, so we'll increase blood perfusion to those nerves as well, right? It also is a analgesic, right? It will decrease pain as far as that goes. And then lidocaine will also stimulate axon regrowth, which is part of the nerve that we're trying to stimulate regrowth. And then you'll see on that list, there's also alpha-lipoic acid. So if you were to Google neuropathy, the first things you're going to see is you should take this, you should take this, you should take this. And the reason for that is there's actually a ton of clinical research and data saying these things help nerves heal faster. They help with neuropathic pain. They do all these really good things, which is true, which is why we put it as part of what we do. The alpha-lipoic acid we do in a separate potential injection. The reason for that is alpha-lipoic acid cannot be mixed with anything else, or else it forms precipitates, which is bad. You don't want to inject precipitates into a person. So that one's given separately. So if these were ever recommended, it's a 1/2 inch 30 gauge needle, so really small, given subcutaneously, which means just right underneath the skin into the areas of most nerve damage. So say my hand is your foot. We're talking about, maybe on top of the foot in here, maybe by the ankles. It really varies based on the patient and where it needs to be, right? So, people say, well, why don't I just take these systemically? Why don't I just take pills of these things? Which you could do. The reason we don't recommend that specifically is because, one, it's going to be very expensive, right? Two, when you take something systemically, it has to go everywhere, right? It doesn't just go straight to the feet, right? Or to the hands or wherever you want it to be. It goes everywhere. So say you also have bad blood flow. Well, how do those things get to those areas anyway? Through your blood flow, right? So if we can give those things specifically into the areas of most nerve damage, we do see quite a bit of difference as far as people's turnaround time, as far as how fast they can come out of the office, right? How fast they respond to treatment and those kind of things. So it does work really, really well. Something new that we've been doing that is actually really exciting is growth factor injections as well. So one thing you'll know if you get accustomed to Nova Integrated Health or physical, is that we're constantly changing. And the reality of it is we have to. There's things that come out all the time, new research saying these things work really well. And if they work really well and we're not doing them, why not, right? So my job as clinical director is to keep us on the forefront of things that work for neuropathy or whatever intervention we're trying to do for a patient. So that's a lot of what I do. So we're constantly changing things. So this presentation I'm giving tonight, in 3 months could be not vastly different, but it could be different because maybe we added something else that we found out works even better. And that's what we do. So if you look just clinically, if you look at data, the average doctor, whether that's a dentist, a chiropractor, a DO, an MD, whoever you're talking about, the average doctor is 7 years behind on clinical research as far as when it comes out, right? So they're practicing in the past. Most of them, not everyone. You probably have a good doctor, but most are. So that's our job as a clinics to stay on the forefront of this. So what are growth factors? Well, they're just exactly like it sounds like. Help regrow tissue. So it's not a stem cell injection or anything like that. Literally the procedure is we would pull your blood from you, we would spin it down in a centrifuge to both what's called platelet-rich plasma and platelet-poor plasma, and then we would put it into a pre-filled syringe with specific activators for those growth factors, and we would re-inject it into specific areas in the legs or the hands, depending on what we're looking at, to actually help those things heal faster. We had a patient just last week who, there's certain patients that come in, there's no rhyme or reason as far as certain patients and whether they're going to respond or not. Sometimes you think somebody's going to respond great and they don't. Sometimes you think they're hopeless and they do beautifully. And I wish there was more of a set on that. And that a lot of that's causative factor. I would say specifically with diabetics or chemotherapy, we have the most success with on average. But this lady was 90% and above in both feet as far as nerve damage. So we did, you know, the electrolyte signaling, we did the vitamin injections, and then we did the growth factors. And she's done 5 of these growth factors injections with everything else. And she went to 40% and 30% nerve damage, which is a huge jump. Typically, once you see something above 85, 90, that's again, is a no man's land. So now that we've added this new therapy, there's this whole other plethora of patients that we can now help that previously we couldn't. And that's part of keeping on top of these different things and making sure we're putting them into play to help people. So really, really exciting, really good thing. And this is just, you know, a couple research documents specifically on the PRP and growth of the regeneration of the nerve and the axon specifically. So just good stuff. You know, it's always good to have research to back up everything you're doing, just to have a reason, a rhyme to the reason, right? Not just say, well, hypothetically it does this. Well, based on research, this is actually what it shows that it does. So it's a really good thing that way too. So physical. Physical is the physical therapy aspect to our clinic. The physical clinic is not open yet, right? So this is the newest thing. Like I say, we're changing constantly because there's something better we can do or something we can do more specifically, we're going to do it. So currently we're in a 2,500 square foot facility. We're going to be moving at the end of the year-ish, it'll be next year, to a 6,200 square foot facility specifically so we can add this to what we do. And the reason for it, you can see it on the tagline, balance centers, right? That's the meat and potatoes of why we're adding physical. Physical has specific proprietary methods that no other physical therapy office uses because they own them, right? They develop them very specifically for balance retraining. So, like I say, one of the things we found is we're helping a lot of patients, which is fantastic, right? We can decrease your pain, we can decrease your numbness, but there's this aspect of retraining the body on how to do certain things. So, for instance, if I, you know, one of my good friends, you know, during the derecho was cutting down some trees and actually got couple of his fingers, didn't cut them off, but cut the tendons, had to have emergency surgery, and then he was in a splint, right? His hand was like this for a month and a half. And when he came out of that splint, he couldn't move these fingers at all. You know, the tendons were all okay. There's nothing physically wrong with it, but just had to relearn how to use that hand and go to physical therapy. Well, think of neuropathy the same way as if you haven't been able to use those legs like you had in the past, you're not able to feel like you did, your gait pattern is going to change. You're going to have more of that wide stance, maybe even a little bit of that penguin walk. Muscles are going to be deactivated. There's going to be all these different nuances going on. So what we've been doing is we've been helping patients decrease their symptoms, right? Well, we want to be more encompassing with these patients. We also want to be able to help retrain them on how to walk, right? So not only do their feet not hurt, not only can they feel the ground, but they can actually walk and do the things that they did before and increase their balance and proprioception and all these really good things. So we're like all in on the physical aspect because we're going to be able to help so many more people in very, very specific ways. And like I say, they have this whole proprietary method that they use with that, which is great. You know, specifically for neurological issues like neuropathy and just specifically for balance. And Brian K. Werner is the guy, if you're a PT or in PT world, you know him, as far as, just being very innovative. And he's actually the guy who came up with all these methods. And then what I did is I just take a couple of resources you go to. I mean, I could do an hour, 2-hour talk just on physical itself. But obviously, I can't do that. So I just put those down there. Person wanted to get more information on those things specifically, and obviously they can get even more specific from there too. They could go to those links and get more information. And this is just one of the things that physical has, is they have these rail systems, right? So you can see how these people are in these harnesses, right? So you can do these balance training things and not have to worry about falls, right? Because these persons are hooked into the harness that's hooked into the ceiling. So you can do a lot better training and figuring out how to do these aspects of normal daily life not have to worry about getting injured, not having to worry about working on bars and hurting your shoulders because you're supporting yourself with all your arms and your shoulders through there. And also the physical therapist doesn't have to worry about trying to hold you up or catching you and ruining their back or doing those kind of things too. So super excited about that. It's going to be able to help a whole lot more people. Currently there is another physical office in the state. They're in Clive. So we'll be the second one in the Des Moines Metro, but we're going to try to be all encompassing specifically for neuropathy and retraining all those aspects under one roof and just being a one-stop shop to help as much as humanly possible. So Nova Integrated Health is our office. Physical will be the new branch that we're putting onto our office. Our current address is 2675 North Ankeny Boulevard, Suite 113 in Ankeny. We're just North Ankeny Boulevard. If you go to North Ankeny Boulevard and 36th exit, right, you're going to come to that Casey's and there's a Unity Point. We're just south off of that. And our number is 515-289-4549. Every patient, no matter what, we do a free consultation for, just to see, hey, what would we recommend for you, right? Everybody's different. I can't just say a blanket statement, hey, here's this thing we're going to do for everybody. So the free consultation lets us say, hey, this is what we do for you specifically, right? I'm sure a lot of it is what we went over tonight. And then, based on percentages or where you're at, this is what we do for you as opposed to Joe down the street, because everybody's different, right? So that free consultation we really like, just because we can dive into a patient's history, dive into what their issues are and give them more specific recommendation instead of just going right into therapy and having no idea, or having to come into the office and, having to charge them for that when we really, let's figure out if we can help you first, those kind of things. So yeah, that's all I had.
Great, thanks, Taylor.
Yeah.
Chris, I don't have access to the chat. Are there any questions that our audience has typed in for us?
I don't see any at this minute, but I did have a quick question for you, Dr. Taylor. So how quickly should someone come in if they're, say I was fascinated by the fact that you said that their 10th chemo treatment, they might start to lose the feeling in their feet.
Yeah.
Is that, so should they come in right away after that? Or?
Sure. So there's over 300 clinics in the country that do what we do, right? And some of them work very, very intimately with cancer centers and things like that for that very aspect, right? The reality of it is the faster we can get a patient in and get working on those issues, the faster they're going to respond, right? There's less damage done at that point in time, less work we have to do. And when you look at it, depending on the patient, right? So cancer is not a contraindication to doing our therapy. So, if a patient's going through active chemo and say they're on a chemotherapy medication that is known to cause neuropathy, we can even be proactive with those patients, say, I'm having these neuropathy symptoms, but I still have 6 treatments left. We say, well, let's get you through those 6 treatments, make sure your neuropathy, do the best job we can. Our job would be to make sure the neuropathy doesn't get any worse, and then try to help them get rid of that as much as possible afterwards. So there's lots of nuances, especially with chemotherapy-induced neuropathy, as far as seeing them, after the symptoms start, during therapy. There's lots of different things you can do. And we've had patients that, went through chemo and then now they're back on chemo. So they're doing kind of more of a proactive, I want to say like treatment course to make sure that their neuropathy doesn't come back too.
That makes sense. There is one question here. If I lost my taste and smell from chemo, is there a treatment to bring those back that you know of?
I don't. You're looking at taste and smell. You're looking at potentially cranial nerve involvement, right? There might be some stuff. But specifically with our therapy, there's no way to target those nerve areas. So like even a person kind of similarly post-stroke is really tough to deal with just because you're looking at brain involvement, right? Central nervous system. Once you get central nervous system involvement, that becomes a lot tougher to deal with. Those are typically bigger nerves and harder involvement. There might be some certain things. I have seen some hypoglossal stimulators that you can use on the tongue and things like that. We don't do anything like that. But there might be something out there, but nothing specifically that we do.
Taylor, this is Dick. I apologize. I had to step out and see a patient. So if you covered this, you don't have to repeat it. Those patients who have peripheral neuropathy and are having proprioception deficiency and balance problems, in addition to the therapies that you discussed, are there any particular shoes or footwear that you recommend that can help help them if they do have proprioception issues?
Sure. So like shoes or those kind of things. You know, you'll see people recommend, I think Nikon is the company. They have like a specific insert in the shoe that has magnets that lots of patients have said work. You know, those one of those things that I don't understand how it works, but I also don't care. You know, if it helps the patient, get them. Shoe wise, you know, typically like your New Balance will have a wider base to it, which would be helpful for stabilization. A lot of patients like I always say it wrong, like the Hoka shoe. It's like a marathon shoe that just has a really big sole on it, you know, especially if pain is an issue as far as that goes. Not necessarily proprioceptive wise. But yeah, nothing specific that we recommend as far as that goes. Like say, I'll mention to a patient, you can try the Nikon inserts. You know, I have seen some special socks and things like that too. But we don't sell anything like that or anything like that. But a patient is more than welcome to try those kind of things. You know, it's kind of like the people who have cramps and they put a bar of Dove soap in their bed and it magically gets rid of their cramps. Hey, if it works, hallelujah, I'm glad.
Wow. We did have a couple other questions. One was, what kind of assessments or tests are included in your free consultation?
Sure. So the consultation is really just a one-on-one with myself, just to go over your case specifically. If we get into the testing and those kind of things, those would go towards insurance, right? Just because, you know, if we're going to do a $600 test, I just wouldn't be able to eat that cost and that kind of thing. So if we get into more of the assessment aspect of it, and a lot of it, yeah, it depends on your insurance. We check those things too. We're not going to, you know, do anything that would, you know, leave with a huge bill or anything crazy. But the consultation is literally, you know, most of what I went over today, you know, as far as what we do, how we do it, how can we help you, your case specifically. Every case is a little bit different. You know, maybe you have a chemotherapy-induced neuropathy, that person's also diabetic, or they have other complicating factors, right? So then we need to really nail in and dial into those aspects and maybe request medical records before, you know, we even consider. Maybe they have a heart issue that we want to just make sure, hey, we're going to be cleared with your cardiologist to do this specific therapy because it is electrical based. We've never had a cardiologist tell us not to do anything, but we always check those things. And that consultation allows us to be able to get all our ducks in a row to figure those things out. Now, what we do with the free consultation, and we used to do it differently, is we piggyback that appointment with, if a person wanted to go forward and do some of those exams if they wanted to. The reality is, just because of what we do and the only person in the state that does it specifically, people drive from up to 3 hours one way to come to our office. So what we used to do is we would do the consultation, then we'd have them reschedule for the exam, which they really didn't like that, which in hindsight was a bad idea anyway. So we just piggyback it. We make a nurse practitioner available if they want to do the exam. There's no, you come into the office, talk to me, talk to one of the nurse practitioners, whoever you talk to, there's no locking you into anything, right? It's literally a consultation. There's no pressure to become a patient. You know, we want this to be a very inviting situation. We want you to feel comfortable at our office, and yeah, we just want to kind of get to know you a little bit before we would recommend anything. There's a lot of people we don't treat. They come in to do the consultation and say, hey, this isn't the first stop. You know, I had one today. I was like, look, you need to go get these tests done first. I need to know if this is going on before we can treat you, because I think there's something else more insidious going on that needs to be potentially taken care of first. Or, hey, you might have MS, not your run-of-the-mill, neuropathy, go get some testing done. If it's not, then hallelujah, come back. So yeah, just because you come in doesn't mean we're going to do anything necessarily, but we do make it available.
Well, and you mentioned it, but the second part of the question was what kind of, what does the insurance industry, how does the insurance industry view?
Yeah, absolutely. So, I mean, we're in with every major carrier, Blue Cross, United, Medicare, Aetna, Humana, all those kind of things. So yeah, as far as the exam goes, there's no problem with insurance covering that. Therapy-wise, and this will get fun. Therapy-wise, every insurance covers the electrical cell signaling treatment because it's not really a complicated, we don't use any like crazy coding or anything like that for that. It's all run-of-the-mill normal coding, which no insurance has issue with except for Blue Cross Blue Shield. They actually came back this year and said, we don't like what you're doing. We're not going to pay for anything you do. And, I mean, and we try to fight them on it and say, hey, look, I have all these, this research. I have all these pre and post tests. I can show clinical evidence. I can show all this stuff. And they said, we don't care. So Blue Cross, I should say this, I should say more specific, Wellmark, Blue Cross Blue Shield will deny those things. And if you look at like the nutrient injections, if we were to do that process, if you had a high percentage of nerve damage, insurance companies aren't going to pay for that. They're going to say that's unwarranted. Or the growth factors, insurance companies they don't pay for anything that's potentially regenerative for the most part. Yeah.
Sounds good. The other question was about this person has a baseline test coming up with their neurologist.
Sure.
Any idea if they should do that first before they come to you, or are the tests similar? Or?
Yeah, I mean, by all means, yeah, the more information we can have, the better. Like say, yeah, neurologists are probably going to do nerve conduction velocity, surface EMG. Those two are typically paired together. So it's good to see, yeah, is there large fiber involvement with it? And here's the thing, like say we do like the epidermis nerve fiber density test, that 3 millimeter punch biopsy. Doesn't require a stitch, just a Band-Aid, heals in about a week. But, that also take with a grain of salt because somebody's active chemo, they have low immune system. We're not going to do a punch biopsy. If a patient comes in with a lot of edema, we're not going to do a biopsy. So we don't always do those tests on every patient. It doesn't say, hey, you got to do these things. Like I say, subjective testing we can do on every patient because there is no, taking a sample of a patient, poking him with a needle, any of that kind of thing. But yeah, the more information we have, the better. Like saying sometimes, unfortunately, the large fiber neuropathy test will come back negative, but obviously the person has neuropathy. So it might just not have spread to the large fiber nerves, might be more in the small fibers. But more information, the better.
Really fascinating. And I think it's exciting that how many people you're able to help, because it can be just really debilitating.
Yeah. And that's really what it's about, Chris. I mean, this is more information people care, I'm sure. But moving from a 2,500 square foot facility to 6,200 square foot, my overhead is tripling. I have to hire a ton more staff. I'm going to make a lot less money. That's the gist of it. But the reality of it is we're going to be able to help so many more people. I get emotional because my father-in-law, or my stepdad died of cancer this year. And he had everything that went along with it. So adding value to people and helping people is what matters to us. And that's why we do what we do. It's not about the dollars. If it was about the dollars, I'd be doing something else. It's about helping people and being able to improve quality of life and things that they couldn't get otherwise.
Yeah. Yeah, that quality of life is it, because that neuropathy can be so defeating. You want to get up, you want to get moving, but if you can't feel your feet, or if it's painful to walk across the room, you're not going to go for a long walk in the fall, or you're not going to go to the gym and get on the treadmill. It's so
Absolutely.
you can really ignite a great deal of helpful energy and excitement, and it's lasting. That's the other thing is, that it's it's not a quick fix that is only going to last for a certain amount of time. It sounds like, you know, the treatments that you do and the things that the way you're able to help people really gets them back in the game, so to speak.
Absolutely.
Which is awesome.
And I will say one thing, Chris, just full transparency, you know, part of our mantra is upfront and honest as much as possible. We get about 11% of people that don't respond to therapy.
Sure.
Right.
Oh, yeah.
So does it work for a lot of people? It does work for a lot of people, but there is a certain percentage, no matter what you do, that aren't going to respond. Right. You know, if I came out and said, if we have a 100% success rate, one, I'd be lying. Right.
Right.
And two, you should run the other way. Right.
Yeah.
So when we look at those things, there is that 11% that, you know, and I tell everybody on that first visit, say, hey, here's our percentages. Whether you're going to fall into that or not, I honestly can't tell you. Because there's too many caveats with every single patient, you know,
right.
Like say if an alcohol-induced neuropathy comes in and they're still drinking heavily, yeah, I'm not going to be able to help you.
Right.
But if they stop, yeah, I mean, the chances go up dramatically. But I always tell people those numbers up front because that matters too.
Oh, absolutely. Dr. Deming, any questions on your end?
No further questions, but Taylor, thank you so much for the presentation. Thank you for sharing your own personal story. And, you know, everyone is touched by cancer. My mom was diagnosed with incurable cancer when I was in high school, you know, so 50 years ago. It's still part of who I am and part of what I do. And so thank you for being personal tonight. Thanks for sharing your story and the information on how you can be of help to people who've gone through cancer. We really appreciate it.
Yeah. Well, thank you for that opportunity, Dr. Deming. Appreciate it.
Thanks again. We really appreciate it. Very, very interesting and meaningful information.